Ibrutinib flare or disease flare on ibrutinib is something that occur, is characterized by worsening of disease-related symptoms or rapid re-enlargement of lymph nodes or spleen, as well as potential for laboratory-associated changes, rising LDH or quickly rising lymphocytosis. And so this can occur both in the setting of temporary interruptions on ibrutinib or drug holds, as well as at the time of discontinuation on ibrutinib, more commonly in the setting of progressive disease. And so when considering this in those two separate situations, in the setting of a temporary interruption, as discussed in an earlier question, the dose interruptions or dose modifications are not infrequently encountered in patients with CLL on ibrutinib due to the ongoing treatment and side effect profile. And so in not all of those situations, a dose reduction would be the right decision, in that peri-procedurally or in the setting of a severe infection, a dose hold is really what's warranted. And so in those settings, I think to reduce the risk for disease flare, which we really do need better ways of identifying who and when this is going to occur, include trying to minimize the time off the therapy. Practically, how this could look is somebody, the labels, the label says hold the drug for 3 to 7 days or consider that pre and post surgery. Say a patient goes in for a colonoscopy and then no polypectomy or no biopsies performed, then the drug can be restarted sooner, the same day or the following day. I think really we can't eliminate all of these holds and all of these flare events, but the take-home message is probably such that you want to avoid a premature discontinuation or transition to a different line of therapy by not mistaking a disease flare event for a true progression event. And so the mainstay of treatment of flare is going to be resuming or reintroduction of the ibrutinib if that's not contraindicated. In the setting of disease progression, where you're planning on stopping, it is a true progression event and you're planning on stopping the therapy, consideration for that transition period is paramount, both if they're going on to a clinical trial where there may be a washout period, or in patients who are going to probably the most common next line therapy in those who haven't received it, which is venetoclax, that usually is going to involve a ramp up period that may leave a gap in effective therapy if you were to abruptly discontinue ibrutinib on day one. So the strategies there include a rapid dose escalation, as well as perhaps an overlap of the two therapies. And I would prefer the latter, in so much as we now have abundant safety data from patients who have not been previously treated with both of these agents, as well as some retrospective data showing that that's safe to overlap at least during the period of a typical ramp up, and that avoids some of the potential for increased TLS risk and things in doing the rapid ramp up approach.